Very good morning to all of you. Today we will discuss about the fascia. So what is fascia? Fascia is an underestimated structure which is present in all our body in our body from head to toe. What do you think about fascia? Whether fascia is plantar fascia, thoracolumbar fascia, or tensor fascia lata? Introduction of the fascia. Fascia has been described as the most pervasive tissue in the body, representing a three-dimensional network from head to toe. It is a type of connective tissue along with tendons, ligament, cartilage, muscle, and bones. It is a avascular structure. Overall, whether it is tendon, ligament, cartilage, muscle, bone, everything is made up of fascia. According to the Federation Committee of Anatomical Terminology in 1998, defined fascia as sheaths, or other dissectable connective tissue aggregations. This includes investments of viscera and dissectable structure related to them. By the great anatomy, masses of connective tissue large enough to be visible to unaided eye. Facial Research Congress in 2009, the term fascia describes the soft tissue component of the connective tissue system that permeates the human body. That is, proper fascia, aponeurosis, ligaments, tendon, superficial fascia, visceral fascia, intramuscular fascia. Everything is fascia. Now come to the magnified structure of the fascia. This is the magnified structure of the fascia. The muscle fiber is moving inside the covering of fascia. You can see the water droplet is moving from one place to the another place within the fascial system. There is presence of blood vessels, nerve, etc. within the fascia. Now come to the component of the fascia. There are three types of components: cellular component, fibrous component, and ground substance. Cellular component are fibroblasts, adipose tissue, adipose cells, macrophages, plasma cells, leukocytes, and mast cells. Fibrous components are collagen fibers and elastin fibers. Ground substance consists of proteoglycans, glycoprotein, exogenous substance, and extracellular fluid. Layer of fascia. There are three layers of fascia: superficial fascia, subserous layer, and deep fascia. Superficial fascia lies beneath the dermis and consists of loose connective tissue and adipose tissue. This layer store water and fat, serve as an insulation, prevent and protect from mechanical deformation. Provide pathway for nerve and blood vessels. This is the histology of superficial fascia. Saphenous vein, paraumbilical vein, lateral region of the ankle shows the superficial peroneal nerve. All these are present within the fascia. Now come to the subserous membrane. This space may enlarge with edema or extravasation, suggesting that fascia can be disrupted and stretched by any injury. Deep fascia. A dense sheath or band of the fibrous connective tissue separate the muscle into functioning group and lines of the body, covers all the organ of the body, epimysium, perimysium, and extension of deep fascia, divides surround and fasciculi, and ultimately each muscle fiber. Function of the deep fascia: contribute contours to the body, provide lubrication between structure for movement, provide nutrition. Now come to the myofascial unit. A myofascial unit is composed of a group of motor units that activate monoarticular and biarticular muscle fibers that move a body segment in a specific direction. Second, a joint that is moved. Third, nerve afferent, receptor or afferent, and vascular component. Fourth, fascia that connects these elements together. All are composed of myofascial unit. The myofascial unit, each myofascial unit has one center of coordination, which is situated in the deep fascia, where vector from muscle fibers contraction converge. When a group of muscle fibers contract together for a particular direction, they will tension their overlying and interfascia, and at a particular area there will be a mathematical point where the vector force will converge in a given movement pattern. A physiological sliding system in the center of coordination is necessary to create a correct final vector. Is fascia is a contractile or non-contractile structure? Previously, it was thought that the myofascia is a non-contractile structure, but now myofibroblasts, a class of special cells present in the fascia, which are capable of exerting clinical significant contractile force in the particular circumstances. So, fascia is a contractile. Now, facial plasticity, a neurobiological explanation. This is the toe region, physiological loading, microfailure, and complete failure. Now come to the facial recoil. Fascia is recoil. And next is water, the key nutrient for fascia. Serve as a body transportation system, help defend the body against the shock, body biomechanical reaction, regulation of body temperature, loading, bearing, and filtration property of fascia, critical for collagen structure and stability. So water help in so many ways and is a key nutrient for the fascia. So water causes collagen fibers to swell, result in mechanical slippage between collagen fibers. Less mechanical force is required to break the addition. The recommendation daily intake of water is based on this formula: 0.6 ounce into body weight in pounds is equal to number of ounces of water per day. Tensegrity of fascia. In human organism is incapable of upright posture without myofascial tension. So this tension is created by the fascia, known as tensegrity of the fascia. Without this, human body is unable to keep upright its position. So this is the three-dimensional view of the fascia in all three directions, how the fascia is present and the pattern of fascia inside the human body. Now come to the fascial lines or myofascial meridians or myokinetic chains or anatomical chains. All these are same things. The superficial, first is superficial back line. Postural function is to support body in full upright extension. Movement function is to create extension and hyperextension except flexion from knee. The bony attachments and muscular attachments are given in figure. So the superficial back line consists of Velia aponeurosis, erector spine, capitis, cervicus, thoracic lumborum, lumbosacral fascia, sacrotuberous ligament, hamstring muscles, gastrocnemius, Achilles tendon, and plantar fascia. This is a superficial back line. Now come to the superficial front line. Postural function is to balance the superficial back line to provide tensile support from top to lift those parts of skeleton which extend forward of the gravity line, pubis, ribcage, and face. Movement function is to create flexion of the trunk and hip, extension at the knee, and dorsiflexion of the foot. The muscles are sternocleidomastoid, sternalis, rectus abdominis, quadriceps, tibialis anterior, and extensor digitorum. Lateral lines, postural function is to balance front and back, and bilateral to balance left and right. Movement function to participate in creating a lateral bend of the body. Muscles include sternocleidomastoid, splenius capitis, external and internal intercostal, external and internal abdominal oblique, gluteus maximus, tensor fascia lata, iliotibial band, and peroneus longus and brevis. Now come to the spiral lines. Postural function is to wrap the body in a double spiral that help to maintain balance across all planes. Movement function is to create immediate spirals and rotation in the body and in eccentric and isometric contraction. To study the trunk and leg to keep it from folding into rotational collapse. Muscles are serratus anterior, internal and external abdominal muscle, tensor fascia lata, bicep femoris, anterior tibialis, and peroneus longus. Now come to the arm lines. Postural function is strain from elbow, affect the mid back and shoulder. Malposition can create significant drag on rib and neck, breathing function, and beyond. Movement function is arm line act across different level of joints in arm to bring things towards us, push them away, push, pull, or stabilize our body, or simply hold some part of the world still for our pursuit and modification. Arm lines are deep front arm line, superficial front arm line, deep back arm line, superficial back arm line. Deep front arm lines, pectoralis major, bicep brachii, radius, thinner eminence of the thumb. These from the deep front arm line. Superficial front arm line, superficial front, pectoralis major, latissimus dorsi, intermuscular septum, and flexor muscles of the forearm. Deep back arm line muscles, rectus capitis, lateralis, levator scapularis to supraspinatus, rhomboidus, infraspinatus, teres minor, tricep brachii, ulnar periosteum, and hypothenar muscle. Superficial back arm line, trapezius, deltoid, lateral intermuscular septum, and common extensor muscles. Functional lines, postural function is these lines have strong postural stabilization function in positioning outside the resting standing posture. Movement function is the function lines appear as a spiral on the body and always work in helical patterns. Functional lines, back functional lines, front functional lines. Back functional lines are latissimus dorsi, lumbosacral fascia, sacral fascia, vastus lateralis, subpatellar tendon. Front functional lines, lower edge of pectoralis major, lateral sheath of abductus abdominis, and adductor longus. Deep front lines are postural function and movement function. Postural functions, lifting the inner arc, stabilizing each segments of the leg, supporting the lumbar spine from the front, stabilize the chest while allowing the expansion and relaxing of breathing. Movement function play a greater role in stability aside from hip adduction and the breathing wave of the diaphragm covered by the myofascia, which duplicate the role performed by the muscle in deep front line. Effect of motor coordination of chronically overstretched myofascial expansion. What happens if the motor coordination is chronically overstretched? Then excessive basal tone of a muscle, muscle myofascial expansion are overstretched. Only particular portion of the fascia in the distal segments are stretched. Muscle spindles associated with this fascia will chronically stretch. Alpha motor neuron continue to activate the muscle fibers associated with these muscle spindles. Chronic contraction of some muscular fibers with increased acetylcholine, imbalance of the joint, referred pain and altered joint range of motion. So this is fascial normal structure and this is the right side fascia structure after the trauma. So now come to the dysfunction. How dysfunction occur? Increase in the viscosity of HA in the center of coordination. HA is hyaluronic acid. Decrease of the sliding system in the center of coordination. Decrease activation of muscle spindle. Improper recruitment of muscle fibers. The resulting vector become faulty. Mechanical incoordination in the articulation. Phase of compensation. Symptoms in the center of perception. So now come to the treatment of myofascial dysfunction. Muscle stretching, instrument assisted soft tissue mobilization, yoga, myofascial release, muscle energy technique, dry needling, kinesiotaping, active release technique, nerve mobilization and rolfing. These are the treatment by which we can treat the dysfunction of the myofascia. Thank you.